So first of all, I'd like to thank Felix and your team for inviting me, giving that talk. It's a great honor and pleasure to be here again. It's like coming home for me. And it's even a greater honor doing that under that name, Lange Symposium, because he was my teacher for a very long time. And that's the greatest pity that he's not here today. So I would like to send my greetings and all the best to him from here. So I had the idea was that I should talk about that topic, and in the very beginning, as I'm a simple cardiologist, I didn't understand, am I for or against that? But finally I got that, I think, because René talked about surgery. So these are my disclosures, and if I'm going to talk about surgery versus intervention, then of course one has to face that. These data that we do surgery is getting more and more problematic in our patients. And you see here only mortality. This is a great database from the STS database. A lot of patients, more than 30,000 redo surgeries which are included there. And these are data from single centers, but quite similar. So what are the problems after surgery or due to surgery? You know all these things, and all these things can cause morbidity and mortality. So I'm not talking about indications today. I only want to show you interventional options which we could offer in our patients. And if you look at this, you're aware that this is a multi-level disease. You do not have only side branch stenosis, but mostly you have that on the right side. You have a stenosis as a distal pulmonary artery or a conduit, and the side branches together. So what are our options in that? We have to face that these are stenosis, as I said, the branches and in the main pulmonary artery, and often they are combined with a dilation of the pulmonary artery and the side branches. We quite often see severe pulmonary regurgitation, which we have to address as well. And mostly, and that's very important, they are post-surgical, these problems, what we see, and seldomly only congenital. So post-arterial switch, follow repair, conduit repair, these are examples for that. So these are challenging pathologies with a need for modified treatment techniques. So it's extremely important to have a good pre-cas imaging, and that's clear. You want to understand what you are treating. You want to know where does it come from, how long is the stenosis, where is it located, are there any structures around which you could affect by doing something, for example, putting a stent in. These are not only vessels, but also the airways, which you have to look at. So that's important to have that in advance. And sometimes even the 3D models can help you to prepare these things and to try out stent implantation and these things, and then you can see a bit more clearly what you're going to do in these patients. And of course, when you finally reach the cath lab, then projections are extremely important, and they are challenging for sure, but it's extremely important to see the structures you want to treat, and you want to have them not shortened. You want to see them in their correct length and position, and to see the ejection structures around. So that's extremely important. So if we look at this case with a stenosis in side branches and in the distal pulmonary artery, you could go for a first step, which would mean a balloon dilation. You could use, and that makes sense, to use this so-called kissing balloon technique, to use two balloons in the side branches, so you have a simultaneous balloon dilation of the distal pulmonary artery, because otherwise you wouldn't be able to have the size for that distal pulmonary artery. But the reality is a bit different. The dilation of pulmonary stenosis in these situations is not very, or is often problematic due to recoil of the vessels. So stents have much better results in this area, as you see here. This balloon stenosis ratio was higher in stents for sure. So if we talk about stent implantation, then we again have to decide whether we go for a single or a double stent implantation, whether we do that simultaneously or one after the other. Ideally, we would like to have non-shortening stents, it's clear, and of course, and that's also important for our growing patients, they should be further dilatable, so coronary stents are definitely not the thing you want to use at that stage. So the hazards, the risks of our procedures are, of course, jailing side branches, and we could milk the stent out. That's really problematic sometimes. And of course, the stent position could prevent a re-entry and a redilation of these stents. So you should think these things in advance before you start stent implantation. Another thing we already heard of are the coronaries. Of course, we know that from the percutaneous pulmonary valve replacement. And the question is, do we need that as well for the pulmonary artery stent implantation? I would say clearly yes. And the more proximal you want to implant your stent, you should also test, make a balloon dilation. For sure not in the bifurcation itself, but if you come more down, that makes sense. These are the things you could win with a pre-stent in this area, that's clear. And of course, finally, you could diminish and narrow your landing zone if you have a large landing zone with your pre-stent like this, and then you finally could put in a melody valve or a sapien valve. Another very interesting technique to treat these kinds of pathologies is so-called Stümper or Standem's technique. He was the one who first reported about that. That's a similar pathology as you have seen already. And here the problem is that this is a very short stenosis, and you have the side branches which look more or less okay. And below you have a valve which possibly is still working well, and you do not want to touch and harm it. So what can you do? To put in a stent, a short stent, of course, could cause a problem to the side branches, and of course, if it's too long, you could get a problem with a pulmonary valve. So what he proposed and did and showed was this kind of technique, this double balloon technique. So this stent was flared was put on two balloons, and which were placed in both side branches. So by this, he was able to implant the stent like this. So it could be flared into the side branches at the same time. And on the one hand, you did not trap the valve with that. That's the way it looked afterwards. And of course, it's lower risk to dissect the vessels, a reduced risk of milking the stent back, and protects the side branches, as you've seen. You might worry about the size of the sheet you would need for that, because you have two balloons. But if you see that, you get an oval shape due to the two balloons beside each other, and an oval shape which would allow you to use a smaller sheet inside. But of course, it's always something you should test before you go inside and do a bench testing on the table with a short sheet to see what sheet size do you definitely need for your assembly. This is a modified Stümper technique, also interesting. It's the same idea. Here, a multi-purpose catheter was placed additionally inside beside the balloon, and this helped this one went into the other side branch. Here the balloon was placed into the right pulmonary artery, the stent in the distal stenosis, and this multi-purpose catheter allowed the guide wire to place in the distal LPA, and finally ballooning there, and as well protecting this side branch from jailing. So that was also interesting. So you have to put then a multi-purpose catheter and a balloon catheter together inside your stent. If we talk about stent implantation, as I said, you could also think about putting in two stents at the same time. And that's important and helpful to do that simultaneously, because then you have the option to dilate also the distal pulmonary artery, as I said already, with the balloons. And of course, it allows a re-entry of these stents. Otherwise, it's quite difficult if they look to each other, these stents in both side branches. It's extremely difficult to get in there later on for redilation. This is another situation with a distal pulmonary artery stenosis, and you see this degenerated shell-high graft with a pulmonary insufficiency. And here in this case, a technique was used to put in a pre-stent in one side branch, and finally, after having done that, coming with a short melody valve, because that was a problem. The landing zone was extremely short, and by folding that valve from its original length of 28 down to 20, by folding the distal and proximal struts, it was possible to treat this anatomy by putting in a valve and at the same time dilating the bifurcation. If we want to stent the bifurcation, the pulmonary artery bifurcation, we can learn a lot from our colleagues from the adult cardiology, of course, because they have this problem already for years, or they are thinking about these problems already for years. And they developed lots of methods to find out what kind of stenting is optimal in this situation. And if you see here bifurcation stenting, they were able to show quite nicely that if you pass the stent which you placed first more distally, you mostly end up with a better result, because you have a shorter carina which you finally have with these two stents, and by this you have a less disturbed flow and a higher flow velocity in the side branch. So these are ideas and thinkings which you should know when you do this stent implantation in both side branches. So that's the way it could look, or does look, in patients with a pulmonary artery and a Y stent. And this is a case with extremely wide pulmonary artery, and after patch enlargement and with a free pulmonary regurg. And here we put in first the stent into the left pulmonary artery, as you've seen before, in order to open the right side, we went through the cells of this primarily implanted stent, put it in another stent through these cells to the right pulmonary artery, and by this having this Y stent in the bifurcation, and that allowed us finally to anchor a melody valve below, and had a more or less good and physiologic result with that. So, and of course, we dilated it a bit with a 24-millimeter balloon. Otherwise, we wouldn't have been able to fit that to the wall of this dilated pulmonary artery. And another example of that, again, a patient a bit older and with a free pulmonary regurg after patch enlargement of the RVOT. And again, the same procedure. We put in two stents and anchored the melody valve below, and that was really helpful to have a good result in this patient. And if everything fails, everything, I mean every interventional options, then we still have that. What René also said, we sometimes need to do the things together, and this is a hybrid, an example for a hybrid implantation, and you see a stent implantation in the right pulmonary artery. You can do that under vision, and it's more accurate to place the stent. It can be fixed surgically, it can be removed. We cannot do that, but the surgeon can remove it if it's not looking perfectly. So that's often very easy to do, and quite helpful also for the surgeon to have that option during his surgery. So to summarize, it's challenging to treat these bifurcations, as you already said, René, and it needs a careful and detailed planning. Sometimes it's better to go for surgery, that's for sure, but we have lots of interventional options We need a lesion-specific approach to that. Modern stent designs, as I've shown you, implantation techniques like tandem stenting, bilateral stenting, Y-stent, all these things can be used and expand the range of lesions which we can treat interventionally. And by this, of course, we have to be aware, often it's an adjunct to the pulmonary valve replacement, so we should think about that if we want to go for pulmonary valve replacement. And to say that, I think it's true as well that surgery often is only second best, especially with regard to higher procedure-related risks. Thank you very much.